Thanks everybody for having me. Thanks for tuning in. Dr. Bill Wagner gave this a presentation very much like this a few weeks ago, and we took a lot of the questions that came up from this, and I tried to incorporate a lot of them in here. So, like Preston said, hopefully at the end there aren't too many questions. If there are, please wait till then. We'll go through them best we can. I might not know the answers. We had one or two last time we had to kind of figure out, but if we don't know them, I'm not going to sit here and make it up. We'll figure something out and we'll get back to you. So tonight I'm going to talk about planning and preparations for BioFlx crown. So two key pieces: planning, picking the right kid, the right tooth, just everything that's the most appropriate for these crowns, and also preparations. If you don't pick the right tooth, you're going to have frustrations and failures. If you don't prep things properly and cement things properly, you're going to have failures and frustrations. So trying to go over these two things to avoid, minimize, or reduce all those headaches and painful things that we've been dealing with, and we do deal with. Again, it's a new material, it's a learning curve, but once you start to learn how to use things appropriately, you'll hopefully have less and less frustrations. So again, that's all my background. Dental school at Temple, went to residency at Temple, and basically since soon after I left residency, I've been involved with our program in our office at the hospital. So enough about me. You don't care about me, you care about BioFlx. So let's talk about what we're going to cover tonight. So next 45 minutes, I'm going to try to squeeze all this in. It's a lot. So this is recorded, so I think you'll have access to this later if you want to go back and review anything. And please feel free to reach out to myself or Preston. But we'll talk about the material, case selections, the good and the bad. We'll talk about the preparations, which again are very important. We'll review some crown sizes and what the kits come in and what's available out there. We'll also talk about cementation. There's just what to use, and one or two things if you don't do them correctly, what can happen. Again, I think we all learn the most just by seeing cases and what worked, what didn't work. So I have 4 or 5 really good cases, I think, that will hopefully, show you some stuff, some troubleshooting, some outside the box thinking sometimes. We'll talk about some of those frequent asked questions that came up last webinar with Dr. Wagner, and open up to questions the last 10 minutes or so. So, all right, so material. So what is BioFlx? So BioFlx, let's not go over what it actually is yet, but what we have here in the States. So I know there's some individuals outside the United States. So within the US, we only have these in posterior crowns. So they are posterior aesthetic resin crown. Some countries, some markets outside of the US, they do have anterior crowns. We do not have those here in the US. So again, I know I'm talking to kind of two different audiences here. So just to clarify. But what BioFlx is, it's an all white. There's no metal in this whatsoever. It's a completely biocompatible resin material. And like I said, next slide or two here, we'll get into exactly what it is. Here in the US, we've had this since around May of 2022. We went through some prototypings and, learning how to use this and sizing and things like that. And then soon after that, it became more widely available. I have one case here I'll show you. They are prototypes. So some of the markings are on the outside, but the markings now are actually nice because they're in the intaglio surface there inside the crown. So, it doesn't become an aesthetic issue or anything like that is there kind of left like an eyesore. So some of the neat things about these crowns, they adapt, they kind of mold, they kind of flex and adapt to your prep, which is nice. We're going to talk about some prep issues that you need to modify and adapt and change your stainless steel crown preps. These are not stainless steel crown preps. They're close, but they're not the same. Stainless steel crowns, we keep buckle bulges. Those are nice. Those are our friends because they can snap over that and retain that crown. With these crowns, they're not our friends. We have to get rid of those. They are radio opaque. They're not as radio opaque, obviously, as zirconia, which is about as radio opaque as possible. And they're not as radio opaque as stainless steel, but they are radio opaque, and you'll see those on some of the x-rays I'll show you. It's kind of nice too, because you almost can see underneath the crown, see what's going on. Zirconia, stainless steel, you really don't have an idea what's going on underneath those crowns. These, you get a little idea of, oh, I should have pulped that tooth, or, what's going on underneath there, or even somehow, like some of the biocompatible and bioactive materials we use, you can kind of see how that is reacting with the pulp and what's going on underneath there. So it's kind of neat. We talked about the markings on the intaglio surface to determine which size they are. That intaglio surface too is also roughened up, which makes it really nice for the cement to grab onto. Um, I think what else, but and then, back to the bottom corner. So you can actually cut these. They do cut. You can trim these. We'll talk about that. Um, I try not to if I don't have to. You will get some kids that have really, really short clinical crowns. You might have to do that. So size them appropriately. You want to probably, if you think it's a size 4 crown, you probably want to use a 3. By the time you cut it, it's closer to a 3.5 or a 4. But if you've been doing this long enough, you guys know that. So, but you can cut these. You can't crimp them. You can't contour them. You can't do those kind of things. So there's some limitations to it, but it's nice because they do flex, they do conform, they do mold these teeth. And it goes back to, your preparations are really key. What's it made of? It's a really high strength resin material that's been used in the medical device industry for years. So again, it's not a new material, it's just a new purpose. It's just been repurposed now, and it's something that the dental industry is taking on. Get this question a lot. Is there any BPAs whatsoever? There's no BPAs in this material at all. So parent asks you that, that's your answer. It's a firm no, there is not. So again, the 3 main types of restorative materials for posterior teeth are your stainless steel crowns, your zirconia crowns, and your BioFlx crowns, or your resin crowns. So I made just a really quick chart here just to kind of outline the pros and cons and just kind of weigh everything out. Stainless steel crowns, again, you can have the most minimal reduced prep, and these will hold up. That's why Hall crowns work. Zirconia crowns, you can't do all crowns. BioFlx crowns, you can't do all crowns. So you have to prep the teeth. In zirconia's case, you have to prep the teeth a fair amount. Placement ease, again, stainless steel, super easy, very forgiving, easy to use. BioFlx, a little more sensitive. There's some things you can't do. You have to, again, reduce some bulges, make sure your occlusion is reduced enough and everything's smooth. And the zirconias are really difficult to place. They can be the most challenging, obviously, of the 3 because of the technique. Aesthetics, that's pretty self-explanatory. The zirconia is about, you can't beat that. The BioFlx, they look good. And then obviously the stainless steel, that's about as basic as you're going to get. And sometimes that's what's best, but aesthetically it's obviously the worst option. Durability, zirconias will withstand a lot of wear and tear. Stainless steel and BioFlx will withstand wear and tear, not to the degree of zirconia. And if you prep these properly, cement these properly, and choose the proper patient, you're going to have a good success. Cost-wise, again, zirconias cost the most out of these 3, then BioFlx, and then the stainless steels. So let's talk about durability of the material. I looked this up. I'm like, why do we use 80 newtons? Like, who came up with that number? So 80 newtons is basically the bite force of a kid that's 6, 7, 8 years old. That obviously increases as the child gets older. So that's why they're using 80 newtons to test on. It's not just some random number they picked out of the air and said, let's just use 80 newtons. So after 80,000 cycles of wear on this BioFlx crown, what happens is essentially that material kind of gets pushed out of the way, makes a small little dimple where that occlusion was at, where that that little pin was dropping on there for wear. But again, there's no wear through whatsoever. Again, the material kind of morphs and molds around that area. Stainless steel, half that amount of cycles. It's not as forgiving in a sense because it has that constant wear and tear, and the material ends up perforating. So you will see some perforations in your BioFlx crowns, but again, it's not a material issue typically. It's a preparation issue. It's something that we, on our end as a provider or an operator, probably didn't do properly or need to do better. So, so again, just to kind of show this from a durability aspect. Dr. Wagner had this slide in last time. This was great. I feel this helps explain things a lot better. So that top row really is how stainless steel and zirconia behave. So you have a bite force on your crown. What happens is that whole entire bite force gets dissipated throughout the whole entire crown and the whole entire tooth. So it gets, spread out equally over everything. What will happen sometimes is that force then will translate to the tooth. The tooth can sometimes submerge. That's where the whole theory and everything behind a Hall crown kind of comes into play. That's a lot of times why you don't get a lot of show through or any kind of wear on your stainless steel or zirconia because of how the tooth is set up and how the force is distributed. With BioFlx, though, again, it's a different material. That force on that opposing force on that one area stays kind of in one area. So the force very minimally gets distributed out in that area. It doesn't get distributed out through the whole entire crown or the tooth. It stays in one little specific area. That's why a lot of times you will see some small dimpling with these crowns. So again, it should not show through, but you will see some dimpling with these crowns, and that's just, again, a function of the material. If you see multiple dimples or show through anything like that, that goes back to your preparation probably was not as it should have been, and that's what the consequence was of that. Again, they're very flexible. These crowns, again, you're not going to get that snap. You're not going to get anything like that when these are not stainless steel crowns. You will almost feel like this resistance, and they kind of just like it's like putting a really tight fitting shoe on. You kind of get in there and just fits, and it fits well. We'll talk later here too. If you do have some bounce back or some, the tooth is the crown's bouncing off of your prep, you have a problem, and we'll talk about why that's going to be a problem. And there's multiple ways you have to figure out what the problem is and troubleshoot this and fix that. Um, so limitations with the material. Again, it's a material. Nothing's perfect with any material. Zirconia has limitations. Stainless steel has limitations. This material also has limitations. So it comes in one shade. So we don't have like lights and extra lights like we do in zirconia. Just kind of a couple things here I put asterisks by. And this slide and a couple slides from now will have that. Very important though, when you take off these crowns, don't use the cleoid end or a really sharp end of a, whatever device or tool you use to take these crowns off. Just be very careful. I would take the broadest instrument you have. If you have a plastic instrument, if you can do that. If you have a spoon excavator that has a really wide spoon end, just gently get to the margin and then just tease that crown back off. Don't dig into it. Don't pull up on it really hard, because what you're going to do is distort the margins on these things. You can kind of, mold them, bend them back. But again, if you don't, you're not so aggressive from the start, you won't have to do that. Again, we talked about this earlier. You can trim these. Make sure you have a nice pair of crown scissors like that if you want. Make sure they're sharp, because if you don't, you're going to get this kind of like wobbly little edge to it. And again, you can't really contour that, crimp that in, or do anything with that. So really sharp scissors are important if you're going to do that. And again, of course, crimping and contouring, you can't, because the material wants to bounce back. So you want to push it in, it's going to kind of bounce back. So I'll show you some of the pictures too. Radiographs, you're going to feel I hope you're going to see these conform very nicely to the teeth. So you actually probably don't need to do that. So they're autoclavable. You guys can autoclave these. They will not change colors. They're not going to change anatomy. They will change anatomy though if you do something not supposed to. So this picture below is lesson learned by me and my staff and the folks at the hospital. So what they did, they took this crown, they put it in a bag, they put it on the very bottom of the autoclave, put a bunch of heavy, instruments, tools, whatever else on top of it. And guess what? When you autoclave something, it heats up, and then you have all this pressure from all the other tools on top of it. It's going to distort. Okay. Could I use this crown again? Absolutely. I could use this crown again. It's a little odd now, how it's distorted, but again, lesson learned. So if you're going to autoclave these, you can completely autoclave them. They're fine. The issue is just tell whoever's doing sterilization, hey, this crown has to go on the very top. You can't put anything on top of it. So again, lesson learned from my end. All right, let's talk about cases, because again, like this is one of the absolute key pieces to this whole thing. So let's talk about what we're not going to do. So we are not going to do this for Hall crowns. These are not Hall crown compatible, friendly, anything. So modified Hall crown, regular Hall crown, don't do it. Bad idea. You're going to get yourself in trouble. If you have a kiddo that's a bruxer, heavy grinder, any kind of things like that, not your friend, not a good idea, not a good choice. Parafunctional habits. You got a kiddo that's constantly putting things in their mouth. He's got a lot of sensory input needs. Those kind of kids are probably not going to have the best outcome with these crowns just because the material is probably not going to end up withstanding all the wear and tear and abuse that they put them through. So again, probably the better option out there as far as aesthetics. I would stay away from the BioFlx crowns in those kids. We always have fun parents in our offices. So if you have a parent that you know is extremely high needs and extremely particular with outcomes as far as color and everything's got to be 100%, these might not be up to the standards of that parent. And the last thing I want to do is obviously go through placement of this and then parents not happy. And, if you have a parent that is of that high level of needs, a zirconia crown is probably your absolute best bet. This is, the BioFlx crowns are going to be much better than the stainless steel. Again, you got to kind of read the room, see how your parent is, see if they're reasonable. If they're reasonable, then, this is an option. It's nice to have maybe a little typodont too in the office and just put a, prep and just put a BioFlx crown on there and show them. Some of my pictures you're going to find too. I don't use flash photography. I don't use flashes on my phone. I take pictures. If you use a flash, you're going to have a very, very bright white tooth and it's going to look like it's out of place. If you just have regular normal lighting, typically these look pretty good. I would also too, if you have a really unmanageable kiddo that possibly will present for a follow-up issue, if this needs to be replaced, you might not want to put this on. You can put them on, and if perforation happens or some other failure or problem, you always could take these off and then probably easily swap on a stainless steel crown if needed. So, all right, let's talk about what we should do in cases we are going to have probably better success with. So the more posterior dentition that's available is going to distribute more of that Newton force, that bite force between more teeth. So you're going to have a lot more occlusal force distribution. So the more teeth you have in the back, probably better off you are. After pulp therapy, completely fine, no issues at all placing these crowns. There's no contraindications there at all. If you have a larger class 2 and a younger patient, typically we'd put a stainless steel crown on that. You can put a BioFlx crown that's completely fine. Last two pieces here, fractured tooth structure and developmental defects. So these teeth are unique because if you've had a fractured tooth in the back for some reason, if it happened recently, that opposing tooth probably has not had time to super erupt. So you're probably fine prepping your BioFlx crown fairly, conservatively and normal. However, though, if it's been some time since that crown was fractured, that tooth above it might have super erupted. So you might have to, really double check your prep and over reduce a little bit so that crown does not end up having a, perforation or have undue forces onto it. Also, developmental defects, again, as those teeth come in, if there starts to be really odd super eruption of the opposing tooth, you might have to be really particular about what and how you prep these teeth. So again, prep them before you cement, check your clearances, make sure everything's good. And then after that, hopefully you have a good outcome. Just to hear a little tidbit about just thinking outside the box. So, this tooth, before you even started prepping this tooth, it's an odd shaped tooth. It's tooth S, but it looks like a premolar. So, just go through my regular prep. I mean, might have reduced the distal a swipe or two more than I would have normally, but in the end, this tooth almost looks like an upper D. So I said, all right, well, let me just make a point here. Let me just put the traditional lower right D on. I put S on. S fit mesial-distally, but didn't cover the buccal bulge. Well, that's not going to work. So again, if you've done this long enough, you know that there's the trick when you can take the upper D and flip it over for the contralateral lower D. So what we did here is that, and that's what ended up happening. So you get a really nice result. Mesial-distally fills the space in, but it has that longer buccal bulge that actually covers that buccal bulge area again. So you can kind of see here in the X-ray how nice that fits, how nice this conforms. If you look on tooth B, the tooth opposing it, that's also a BioFlx crown. Again, you can't crimp or contour these. They fit really tight and really nice, these teeth. Radiopacity wise, they are not, blazing white. You cannot see like this, zirconia stainless steel kind of radio opacity, but you definitely can tell there is something on that tooth. So another little point to notice from this is the occlusion I have between tooth B and tooth S. It's extremely light, if not non-existent. And I'll show you another case where that's a nice thing if you can have that, because those teeth will erupt back together, and then your chance of having a dimple or a show through or anything like that is extremely minimal. All right, so again, before you even start prepping this tooth, you want to just check this kid's occlusion. Again, ultimately, you want to restore everything as it was. The last thing you want to do is increase the VDO. That's what we talked about. Hall crowns are not your friend. They are not a good situation for this material. I always like looking at, if I'm doing D's, N's, or whatever the case, look at the canines, and not always the side you're doing the canines on, sometimes the contralateral side, because that should then be an occlusion. If that's not an occlusion, you probably opened up the side you worked on. So again, always check those canines if you can, if they're there, as far as referencing your occlusion, if you ended up doing multiples on one side. Otherwise, you probably have some natural tooth structure that's still in contact. All right, let's talk about preps. Again, kind of another checklist. So again, first thing you do before you prep these teeth, just take a time out. After you get the kid numb, take the extra 10 seconds and just do a mental checklist. Check the occlusion. Okay, make a note of what it looks like and what I'm trying to reproduce when I'm done. Again, I teach residents all the time, so I'm used to teaching individuals who have not done this as much. So we don't talk about this a lot in pedo, but check for the curve of Spee, check for the curve of Wilson. So you may have a really dramatic curve of Spee and curve of Wilson. Make sure you're prepping those teeth with that curve of Spee or curve of Wilson. Those curves can be extremely deep. They can be flat. A lot of kids have more flat curves of Spee and Wilson. It can be even reversed. So just make sure you're checking this, and then you're following the contour of that tooth, how it started, and you're reducing it appropriately. We talked about this a few slides previously. Check the anatomy. When that kid's numb, just when you're sitting there waiting, just look in there and say, hey, that looks like an E1 or an E2 or whatever the case. And then maybe you have an idea of what you're looking for. In zirconias, we do have narrows for D's and E's. However, we only have narrows for the D's in the BioFlx. And I'll touch on that briefly here when I show you the kits. Again, if you have some space loss back to back, you probably don't have to take as much interproximally away, because the material will conform a little bit. So you will get a little more give at that interproximal area between whatever D's and E's you're doing, if you are doing back-to-back crowns. And again, we talked about if you have an odd shaped tooth, you always can use do the trick of flipping it around. All right, so preps. This is probably, again, we've already talked now about planning it, picking the right kid. Now the most important part is let's prep it properly. Because again, either one of those you choose wrong, you're going to end up having a headache. So occlusal reduction should be about 1.5 up to 2 millimeters. Again, just follow the outline of the tooth, follow the contour of the occlusion. Ultimately, in the end, it's going to be fairly flat. There will be some, wave to it and some anatomy to your prep, but for the most part, it's going to be fairly flat. So again, do you have to use a diamond for this? I mean, a diamond football? No, you don't have to. You can use a pancake burr, a disc burr, whatever you want. I personally use 6 or 8 round burrs, because I can remove the decay then with those. So again, it's not necessarily what you're using, it's how you're doing it and how you're using it. So again, make sure the buccal and lingual cusps were reduced, and then also to the marginal ridges. So this is the easy part. This is the more important part. Make sure you're putting a second plane on the buccal and lingual aspects of these crowns. Again, you don't want little blocks. You don't want little cubes as far as your final prep or Lego pieces. You want like gumdrops. You want like everything should be rounded, smooth, contoured. If you have any high spots, if you have any sharp spots, it's going to be a problem. If you've prepped zirconia crowns, you know that. If you prep zirconia crowns, you can do these. It's not a big deal. If you've prepped stainless steel, we all have, you can do these. You just have to make some modifications. And like with anything too, if there's any oddball, cusp or anything that's like outside the norm, they have to go. You have to get rid of those. So after we've done this, What I like to do, again, if you don't use a rubber dam or you have a isolate or something like that, get that out of there and just check your occlusion. If you've gotten good with this, you're comfortable, and you can eyeball this and say, yeah, I have my 1.5 mm of occlusal reduction, then you're good. If you're just not sure, then, we all have these pluggers. We all have ball burnishers, I assume, in our kits. You can take that ball burnisher and that, or that plugger, just run it between the occlusion. Those are about 1 mm each. So if you can get easy clearance without banging in anything, you probably have clearance. Again, this kid's curve of speed is pretty flat. So again, little things like that you just kind of take notice of. So little tools you can use at your disposal to check. Again, and approximately reduction. Again, you can use a diamond, thin diamond burr if you want. You can use a 169. You can use a 700. It doesn't matter as long as you guys are kind to the gum tissue, the gingiva, and also you reduce things appropriately. In my opinion, it doesn't matter what you do, as long as you get to the end result. Again, you just need to get that burr through there, so you only need about 1 mm. Again, you don't need a lot of bulk of material. This is a very, very thin material. Okay, buckle bulges. We talked about this. Buckle bulges, again, stainless steel crowns. Some say you keep them, some say you don't. That's not up for discussion with this. This is a get rid of them. Buckle bulges are going to be a headache. What happens is if you keep that buckle bulge, you're going to try to seat your crown. You're going to seat this BioFlx crown. You're going to get to that buckle bulge, and it's going to sit there and sit for a second. It's going to pop right back. When that pops back up or that bumps back up, it's going to cause an issue with the cement down the road. It's going to leave a void under there. We'll talk about that and what happens. So please, please, please make a valiant effort to get rid of those buckle bulges because they are going to be, a headache. And again, everything has to be rounded off and really smooth. So again, these crowns, when they fit, they should fit snug. They should fit firm, but they should not bounce back. If they're bouncing back, you probably have some issue at a margin, buccolingually, mesiodistally. And again, if they're bouncing back, you may even have an occlusal issue. The occlusal issues are a lot easier to check. The other issues are a little trickier. So if it's not an occlusal issue, it's probably something circumferentially around the tooth that's the issue. But make sure these buckle bulges go. Again, ultimately in the end, if you can kind of look at these preps on the left, again, they're rounded, they're smooth, they're not like big boxy Lego chunky pieces. They are smooth, and they all kind of contour and taper towards the occlusal surface. So again, everything's rounded. You can go through all these steps, and in the end, just kind of take another look. You might have to kind of smooth some spots up, smooth some line angles up, make sure there's nothing really sharp. It's not going to do you any good. Again, if you get a kit of these, flip these over, look at the intaglio surface, kind of like burn that in your brain of like, this is what I'm trying to reproduce as far as my prep goes. Again, if you're getting that bounce back, you have a problem, and you either have a crown that's too small or your prep is too tapered as it approaches the gingiva. So you have to kind of tuck all that in or reduce more there because it's going to cause a problem later on. You'll see in one or two of the cases, you actually can see how these fit sub G. Sometimes you actually see the white in the sulcus, so you can kind of confirm that. So again, they should sit subgingivally. And again, once you get these on, just make sure that's not the first place that you're not having any heavy occlusion, any problems like that on this crown. If you are and you've reduced everything and you think you have the most perfect prep, the only really solution to that is, without touching your prep up anymore, is to adjust the opposing tooth. One thing you'd never want to do is actually adjust or modify the occlusion on one of the BioFlx crowns. You're going to end up perforating the thing. So do not touch a handpiece to a BioFlx crown. That's a no-no. So we talked about, again, these fit pretty snug. Use your fingers to deliver these. Don't sit there and use the band seater and use the metal end that serrated. Don't do that. If you're doing that, you're pushing way too hard and you're forcing it. So these should go on with tactile, just your thumb, just finger pressure. You should not have to do anything more than that. And we did talk about when you remove these, be very careful, because if you don't, you're going to end up distorting the edges or distorting the margins of the crown. All right, let's go over some sizes and kits and what we have available. So again, I can try to got two audiences here between the US and abroad. So right now, regular widths are available in the US and abroad in Ds and Es. So you can like look at the picture there to the right. We do have narrows here in the US currently, but only for the Ds, not for the Es. The difference between narrow and regular is about 0.75 millimeters mesial-distally. However, buccal-lingually, exactly the same, no differences there. So again, it's just a narrow, as it says, more narrow crown. The nice thing I like that they did with these, they have a wide variety of sizes. Some crown companies start an E2 and go to an E7, and I can't tell you how many times during a day or in a week or a month, whatever, I want an E1 and I have to go to a D7 or a D6 or something. It's a headache. So they do have E1, which is really nice if you have a really, really small crown, which again, there are kids with really small teeth out there. Obviously, don't prep those too much mesiodistally, but it's nice to have that as an option to have E1s and even D1s. Don't think I've ever used a D1, but E1s I could use, probably a fair amount, especially with some space loss too. This is our kit we have on the left. So that's all our regulars. They live in there. Those are all our Ds and Es. And as you can see, they run from a 1 to a 7. So lots of options there. Again, I got a bunch of E1s and E1s there on the bottom. D1s, they've been hanging out there for a while. They'll probably be there for a long time. And then the narrow kit is a separate kit in a separate box. Again, only in the US at this point. That's available in the Ds. So that's a separate box. Reimbursement. Let's get paid for what we do. So in the US, we use the ADA codes. BioFlx is coded as a D2932 or a prefabricated resin crown. Problem is, very few insurance companies at this point reimburse for it. I will tell you, please don't just look that code up and, oh, someone's reimbursing for it. Make sure you specifically check for posterior teeth because a lot of times they'll cover for anterior teeth, not the posterior ones. So just double check that. They might downgrade your fee or your reimbursement to stainless steel. It's hard to say. A lot of us had this issue with zirconias back in the day because zirconia wasn't covered by many plans, and slowly but surely they became more and more readily covered. So again, hopefully with some time, this will become, a more widely covered service. Listen, and if you prep, you place, and you cement a resin crown, you're going to have to bill for one and code for one too. So don't try something else like you're not supposed to. We had that question come up last time. That's why that's in there. All right, cementation, what can I use? Self-setting RMGI. We use Fuji Sem 2. Works great. You also can use Keytac if you want. So either one of those is our recommendation as far as that goes. What should you not use? Don't use a light cured cement. The reason is this material is opaque. It's not going to allow the curing light to go through the material, so your cement will never harden up. That doesn't really do anybody any good. So BioSem, the new Smile has, is not appropriate for this. So please stick with your, Fuji Sem 2 or Keytac, whatever you want to use. Again, we talked about if you're going to adjust these teeth, do not adjust the BioFlx crowns, adjust the opposing tooth. But the reality is you probably didn't prep it just right, or when you delivered it, something was off. So again, some little bit of research internally that we had available. These crowns, they stay on really well. So the BioFlx crowns with the Fuji 1, 2, or Keytac all has a really, really good retentive strength. So all recommended for the BioFlx. This is what we talked about really quick. This is why I told you if you get a crown that you put on there and it bounces back, you're going to be in trouble. This is the bounce back issue. Basically, I live in the Northeast, so we have sinkholes. Sinkholes are basically, we have limestone, all the water washes underneath and takes the limestone away, and then when you get a sinkhole. So same kind of thing here. If you try to seat one of these crowns and it has bounce back, you're going to push that crown down. It's going to sit for a second, but it's going to bounce back. And when it bounces back, you're going to have a void underneath that crown. That void essentially means there's no support for that crown. So that force that crown is now, it's the occlusion's high, and then on top of that, there's no support of cement underneath. So it's not going to take a whole lot of wear and tear to get a perforation, or in this case, as you can see from the lab, a much bigger dimple that leads to a perforation ultimately. So again, It's not the material, it's us, it's the operator that we need to do a better job and learn from our mistakes. All right, let me see how I'm doing on time here. About 15 minutes. So I got some cases to go over in about 10 minutes. So um, again, newer material, one study out, again, basically compared BioFlx crowns to stainless steel crowns. In the end, they both held up well after a year. Obviously, the BioFlx crowns are going to look a lot better. So, all right, let's talk about some cases. So this kiddo was 7. These are prototype crowns I'm going to show you. So they're going to be a little more white than what the crowns that are available now, and the labels are on the lingual side. So fairly involved lesions on K&L. Go in there, reduce the occlusion, take the decay out, decide if we have to pulp these or not. We chose not to, we didn't have to. By the time I got back in there, got isolation, got my mirror in place, started to have a little bit of heme around the teeth. So I wish they weren't as bad as far as the bleeding around the crowns go. But you can kind of see, hopefully you can appreciate everything's fairly rounded, fairly conservative preps, nothing too crazy. And then these are our crowns we placed, again, on tooth K&L. You can kind of see here, much like zirconias, if you place those, the labels are sub G. So again, they're not there anymore, so we don't have that as a reference point. But you can appreciate at least there's about 1 millimeter or 2 of subgingival seeding, especially on tooth L. The other thing you want to check is the occlusion. Again, I have this kid's canines back where they started at. I have, I think, a fairly, I wouldn't say light occlusion because there is occlusion, but it's not heavy where just those crowns are hitting. So again, these are some of the first ones I did. So I learned from things too as well. Brought them back 3 weeks later. Again, within those first 3 weeks, you can kind of see on K&L in that far left picture, there's small little dimples or little depressions there. So again, nothing structurally that's detrimental to the tooth, but just aesthetically it looks a little off, a little different. And again, I don't think anybody else is looking in there except us. It's going to notice those kind of small little details. If you look at the x-rays too, again, you can kind of see how tight those crowns really fit to those teeth. Sometimes it's really hard to tell where your margins are at just because of again, the opacity is not that great, but also they fit so tight to your preps. 18 months later, again, this is the longest kid I've ever had come back at this point, because these were the prototypes. But you can kind of see, those little wear spots may have gotten a little broader, a little bigger, but again, no perforations, nothing, perforated through the crown. So short term, some small changes, but long term, fairly stable. Nice to see on the right on the x-ray too. You can kind of see where those crowns fit. You can see underneath. So again, if you had a tooth, you did MTA on, or you did some kind of direct pulp cap, you can kind of see how the pulp's responding, which is kind of a really cool feature, I think, with these crowns. All right, here's another case. Again, this is just one single tooth. This is a 5-year-old came in. Parents had no interest in anything else but a white crown. I said, it's fine. She was a fairly well-behaved kid. Had a larger restoration that was placed, and starting to fail on Jay. This is our final prep here, kept everything fairly rounded. You can kind of see we still have a little bit of enamel on the outside. So again, fairly conservative. This is our immediate cementation right afterwards. Again, the marginal ridges are lined up. That's a good reference point to make sure you're not too high. Make sure your marginal ridges are lined up. Again, your emergence profile was really nice with Jay. As far as the x-ray goes, that was our start. This is our immediate post-op. Again, it's really nice. The chance of number 14 ever getting hung up on a tooth like that is next to impossible, unless that tooth is already, so inclined. So having ectopic teeth, having crowns that are overhung usually doesn't happen. So again, these crowns hug really nice to these teeth. This girl went back to a different office that's outside of our office, outside of our hospital office. So I had an x-ray taken over, but I couldn't get a clinical pic. But that's what it looked like 10 months later. So, all right. All right, let's talk in a bigger case now. So this kid came in, he was 5. Mom had no desire to have stainless steel. The cost for zirconia was going to be outside of her kind of means. So we said, well, let's kind of park in the middle. So we did we did BioFlx. So again, this kiddo needed, I think, don't hold me to this, I think he needed 5 or 6 in the end. But you can kind of see tooth A is fairly involved. Tooth I, you can imagine, is fairly involved. Tooth L down here in the corner is really involved, and tooth S is also involved. And there's some other interproximal lesions on the E's. So again, we broke this up into a 1 sedation and 1 op visit just to make it fair for this kid. So this is our final prep. Got that crown seated. What I'll do sometimes too, just if I'm not in this case, but for I think it was tooth L, I'll take a picture right before I cement it just to make sure I got like coverage. So again, this is that picture you're seeing on the right side is actually without cement, and then with cement it all kind of fills back in. Okay, so this was tooth L. Tooth L was a little more involved. So cleaned it out, put some MTA down there, prepped it, tried to keep it as clean as I could, and then got that on, got that cemented. So the key takeaway here is there's a nice little bit of clearance right between those two crowns. So the occlusion there is not heavy or really not even existent. So, and you'll see when I saw this kid 4 weeks later, that occlusion starts to kind of come back into play, almost like a hall crown where the teeth will re-erupt and come into occlusion, the other ones around them. So again, I don't get me wrong. I'm sure some of you could argue, wow, you probably should have taken out L. Listen, I know that was right at the fence, but that pulp was still healthy when I got in there. So put some MTA down, took just a real quick bite wing just to make sure I had clearance and just to make sure I had coverage, excuse me, and a seal. So with the MTA, the cement, and that crown fitting so tight, I felt comfortable with that. So we cemented that on. So that was the bottom left quad. Went to his top right. A and B both needed crowns. Again, if you take pictures of these for your website or just social media, don't use a flash because they will look a lot better. If you use a flash, they're going to look a lot brighter because of the material. And again, nice conformed, crowns around A. Hopefully 3 won't get stuck there. We'll be fine. And then in the end, this was the end of the first day. So we did A, B, I, and L for this kiddo. And you can kind of see I now have a little bit of clearance there, which is what we want. He came back next time. We had to put a crown on S. At this point, prepped it just nice. Again, I probably should have rounded things off maybe a little more, but either way, it fit great. Got S cemented on there. And again, you can check your occlusion. So again, I got a good 1.5 mm. I can put that plugger through there or whatever I need to just to kind of double check that. And then that's my final cementation. Again, the gum tissue that'll come back and heal up in another couple days, hopefully in a week or so. So again, here's the follow-up. So that same day from the teeth we did 4 weeks previously. So if you look at A, there's a small little dimple there. That's it. B, no dimple at all. If you look at I, no dimple. When you look at L, no dimple, no nothing. Looks great. Again, the reason is the occlusion there was very light. If you look at the picture on the far right, you can kind of see that occlusion is just starting to come back into play. These will retain some plaque, okay? So these are not, zirconias are like glass. Nothing sticks to those. These are, probably equivalent to stainless steel. They're going to retain some plaque. So again, you got to make sure you're brushing there. He did not brush that morning. But zirconias will, basically slough off any kind of plaque. These, though, will attract a little bit. So that's what his upper arch looked like after that 4 weeks. And then his occlusion on the left side looks really nice. And then that's what he looked like at the end of that. Once he got all of his, what was that, 5 or 6 BioFlx crowns on there. So hopefully I'll have some updated pictures with him in another month or so when he comes back for a 6-month checkup. All right. I'm going to get 1 or 2 more cases in here and wrap this up. So this was probably my last case. This was an interesting one because this patient was 15. Why does a 15-year-old have tooth A? Well, she's got no successor. Really poor fitting crown, open margin, just not a great situation. Didn't qualify for ortho. So we had to get this crown off. So we cut the crown off. Obviously modified the prep to get rid of that distal little overhang on A, and then got our crown seated. So looks good, covers everything. Again, those marginal ridges are at or right below the adjacent teeth's marginal ridges. Emergence profile looks really good for this kiddo. And then the X-ray turned out amazing, just because this is so sealed up so nicely. So really tough situation to start with that crown on A that stands steel, but ended up being a really nice result for this kiddo. And then this was 6 months later. So going strong. And is there the smallest little dimple by that cuspid carabelli? Maybe. But again, this kid has so many teeth to distribute occlusal forces to that that's probably not going to be any dimpling on this tooth at all. Again, gum tissue, gingival tissue looks really healthy. All right, this is my last buddy. He was supposed to come in 2 weeks ago. I was going to show you pictures from about 18 months afterwards, but he forgot to come in. So hopefully he's coming in next week. But real quick, he had amelogenesis imperfecta. A lot of these teeth were broken down. And approximately there was a lot of other issues going on, but we ended up doing four visits, just kind of chipped away at it and got all these back teeth crowned. And he was only 9. As you can see, his 12-year molars are coming in. These guys, usually have some expedited eruption of teeth. So he's probably 10 and a half now, I believe. So I'm sure by the next time I see him next week, he's going to have half these teeth exfoliated. So again, nice occlusion, good emergence profiles. So, and that's where this is about 12 months later. So again, don't use your flash photography. You'll have a much better picture. All right. Last two or three slides here. Then we're done. So, some questions that came up last time. How do we manage perforated crowns? Well, again, self-reflect on what happened. Probably was something on the operator end of it. Bottom line, you just cut these off like normal, replace them, but you're going to have to end up going in there and modifying your prep because there was a problem already from the get-go. Disclosing solution. If anybody still uses that, I would avoid that. It will stain these teeth. Yes, you can get it off with just toothpaste and stuff, but again, it's going to be a little alarming if they use that. So I would just minimize the use of disclosing solution. Some folks ask about banded loops. You can use basically any cement out there for banded loops. You can banded loop these crowns. Again, just make sure they fit snug, but not too tight against the banded loops against the crowns. One question that came up last time, SDF. Does SDF stain these? SDF will cause ever so slight staining. So if you look at the very top right slide, that's SDF. And then once it's like brushed off, you have just the ever so small little speckles. And then honestly, you're not going to really see any of it once it's like cleaned off. So you can use SDF, obviously not on the crown. That's not the intent, but on the adjacent tooth, and you should have minimal issues with the crowns. I got also a question came up last time. Can I bond resin to these in case I have clear aligners? We don't know the answer to that yet. So we're working on it. Lastly, here's what we talked about. We all make mistakes. We all have some failures. We all have learning curves. So again, we talk about these. So again, a lot of these cases are probably either had bounce back. They ended up not having proper reduction. So always check your occlusion. Always make sure you pick the right kid like we talked about. And then always make sure your crowns fit snug, but don't bounce back. And these issues hopefully will be minimal to non-existent in your endeavors. So again, case selection is key. If you pick the right kid, you're going to have more success and less frustrations. The preparations, again, round everything, makes things as smooth as possible. Probably a little more involved than your stainless steel crown preps. Buckle bulges absolutely have to go. That's a big hang up, I feel, for some people trying to learn how to do this. And again, like any material, BioFlx is a dental material. It has limitations. So we have to learn how to work with those. Zirconia has limitations, stainless steel, everything does. So that's about it. So I ran about 2 minutes over, but so.
You're good.
All right. I didn't see any questions pop up, but I know there are some. So
Yeah.
I'll let Preston kind of, give me a heads up and I'll do my best to answer them.
There's 147 of them. I don't know if it went too well, so I'm just kidding.
Why, dude? Why?
I'm just kidding. There's only about 9 of them. So, and I think we'll be able to run through them. Thank you again. Yeah, that went really well. So, let's start off. We've got the first one we have. Can you use them on first permanent molars?
Okay. That's a loaded question. So the answer is, have I? Yes, I have. I've used them on a fair amount, actually. So was that the original intent? No. Can you? You absolutely can. Do we have any long-term studies of what they're going to look like and how they're going to end up? No, but I didn't share any cases of that with anybody because I think the primary teeth are the most, the biggest thing we got to master first. But I've probably done 24 cases of kids with adult 6-year molars. Um, Again, you have to have a small 6-year molar to start with. Because again, E7, E6 is the only thing you have as far as that goes. But yes, I do have cases I've done. I've seen it work. It's a good, intermediate if you don't want stainless steel, but the kid's not ready for something more permanent. So the answer is yes. But yeah, if you wanted to see some cases, just reach out to Preston or myself, and then I can talk to you.
That's what I was gonna say. Okay. Awesome. Next question. Does all the decay have to be removed for these crowns?
I think that's a judgment call. I mean, we're obviously trying to, be conservative as possible. If you're going to do an indirect pulp cap, do an indirect, you know, um, you know, you have to have really good clean margins. So, it's just like any other crown. These crowns are not going to change how remove your caries. So if you remove all the caries and, or keep some and do a stainless steel, you can do the same thing for this. It's not going to impact that. So it's just it's how you practice. I mean, and what the tooth basically dictates. So the crown doesn't have anything, I think, that's going to change that.
I think you might have, but what's the prognosis with bruxism?
Um, I, I don't know because probably not a good choice. So prognosis is probably pretty bad. So I would again, like the thing we talked about, just avoid those cases. If you're going to do them, you're going to try them, then be prepared for a failure or be prepared for probably a higher likelihood of having dimpling or, perforation. But, you know, that's something that you'll have to live with and manage on your own as a provider.
Can we use Reliax cement?
Um, can't remember off the top of my head what Reliax is exactly from that end, but again, if you have a glass ionomer cement, um, anything like that, you can use that glass ionomer, resin modified glass ionomer that's self-setting. Those are like your best bets. So I'm gonna apologize and draw a blank here. I don't know where Reliax falls, so I
I
haven't
think
used
it's a
that.
GI, and I think I've had some clinicians
Yeah.
say that
So
they used it. So
yeah. So you should be fine as long as it's a GI or a resin modified GI that's self-setting, not, if it needs a light to cure, not going to work. Anything else should be fine.
what would happen if the crown seated well with no bounce back, but the crown size itself may seem a little too big?
Um, eh, I think that's a balancing act between, do you keep that and deal with it and just, say, hey, this is the best I got, or do you go back in there and modify your prep somewhere and try to get that one size smaller on there? Um, that's a clinical judgment situation that you're going to have to manage in the moment. Obviously, having a bigger crown, you're going to have some probably more gingival irritation. So I would try to avoid that and probably go back in there and modify your prep in some place to, get something more appropriate, the size smaller to fit.
Okay. We've got a couple of questions. I think it was over one of your radiographs regarding the overhang. Uh,
Mhm.
so yeah, there's two over it. So it's pretty, what do you do with the overhang? Is it gonna cause any problem?
I haven't seen any issues with any overhangs. I mean, nothing fits perfectly. We've all had stainless steel crowns that have, some type of overhang. They're never perfect. But you will have a little bit of overhang there. I haven't seen anything come back that's like, um, horribly inflamed gums or anything like that. So you should just leave those alone. They don't, these crowns for some reason, like they're not super long, so they don't really sit way in the sulcus. So they're again, I haven't had any issues with that. Again, you're not going to have perfectly fitting crowns, but you're going to have really tight fitting crowns. So you should be fine.
Okay. I guess the same thing on that overhang is how to explain to parents the overhang if it shows in the X-ray.
I think the overhangs. So I think the overhang. So maybe a good way to explain this is we probably have the exact same, if not worse, overhangs in our stainless steel crowns. But given that they're radio opaque, it's really hard to, I think, see that overhang that dramatically. With these, sometimes you can see that a little more because you can kind of see underneath the crown. Um, I mean, every tooth's different. If you have a really constricted tooth, you're never going to get a crown, no matter what, to fit and hug that as possible, as close as possible. So, I mean, I would always tell the parent, listen, nothing we have is going to replicate what was put there originally. We're just trying to make it as close as possible. And honestly, the cement will fill in those voids and those overhangs. So hopefully that will, not result in any kind of negative gingival issue as long as the hygiene's still, fairly good.
Yeah. I'm going to do about two more questions.
Yeah.
If you did answer a question, we're not able to get to it, I will respond offline, or I have Dr. Bahn respond to you offline. I just don't want to keep everyone too late. So this question I have, if BioFlx are not fully radiopaque, radiopaque, how do AI software in Dynacat or Vita Health view them? I do see them as overhang composites. Is that
That's over my head.
okay? Yeah.
I'm not gonna. I'm not even gonna try to make up an answer for that one. So
Okay. All right. Well, to be continued. We'll get to it. We'll
we'll,
answer
we'll
it.
we'll digest that and get back as best we can, or reach out and maybe you can help us clarify what you're looking for. So that's yeah, it's a
Okay.
lot.
Okay. Are these available for permanent molars yet? Not at the moment. And let me see if I can answer one more. Okay, yeah. Love BioFlex. Thanks for the great presentation. My biggest challenge is with mesial drift space loss. Suggestion for buccal lingual gapping.
So I don't know. So the person asked this good question. Headache we all deal with. Hopefully, if you don't have a narrow kit, order the narrow kits. Hopefully that will give you some, um, you know, an out or a fix for some of those issues. Um, I think that's one of your only options, really. I mean, you can modify your preps as much as possible, and then hopefully those narrows, if you have those, they're going to be about, again, like we said, 0.75 millimeters more narrow. So that's an option as far as resolution there. And it's just probably just modifying your prep to get everything looking as best you can. So no matter what, that's a big challenge we all deal with. And again, you're trying to make the most out of a really tough situation when it comes to that.